So hello, my name is Amy Vandenbroek. I'm the Executive Director of the National POLST Paradigm. And I'm very excited to introduce Christine Wilkins, who will be talking on redesigning patient care using eMOLST, One Healthcare Systems Experience. Christine is the Social Worker Advisor for the National POLST Paradigm. She is also the Advanced Care Planning Program Manager at NYU Langone Health. And I've personally seen her present on what she's been doing at NYU Langone Health for I think a couple of years now, and I'm just always impressed and very excited about the work that they're doing. So I'm thrilled that she's able to present what's been going on there, and hopefully it's helpful for all of you. Please feel free to type into the chat.
Thank you, Amy, and thank you so much for inviting me to conduct this webinar. This is all very exciting. Okay, let me figure this out. Sorry, okay. So I'm going to be focusing on how eMOLST was implemented here at NYU Langone Health. I'm going to talk a little bit about what we have developed in our electronic medical record to make it easier to document and to retrieve advanced care planning. I'm going to talk about how we change our code status order options to mirror MOLST. I will be going into staff training and collaboration with community partners. Okay. So just a little bit of context. So NYU Langone is a large medical system, health system in New York City. And our mission is to serve, teach, and discover, and our vision is to become a world-class, patient-centered, integrated academic medical center. I'm not going to go into all these different rankings. It is a teaching hospital for New York University, and we currently have 3 hospitals. So Tisch Hospital is sort of the oldest, and it has around 700 beds, although that is kind of changing a little bit. Kimmel Hospital, that was opened in June of last year, is a state-of-the-art new hospital with a children's hospital within that hospital, and it has around 374 single rooms, which is very exciting for me in particular because it means we can have better advanced care planning for those patients admitted in single rooms, so that makes it better for us. And then we have NYU Langone Hospital in Brooklyn, which has around 450 beds. And we have, soon we'll have a hospital, NYU Winthrop, which is out in Long Island, which will be our, I guess, 4th hospital joining. We also have an orthopedic hospital and for acute rehab. And we have an extensive ambulatory care family health centers, especially in the Brooklyn area. This is just a quick map, but just to say we're kind of continuing to expand. And I'm going to talk a little bit now about advanced care planning at NYU Langone Health to provide some context to why we introduced eMOLST here. So advanced care planning really started here in terms of kind of a distinct effort to really enhance advanced care planning. That started around 2014. My position was created around December of 2015, so I'm the Advanced Care Planning Program Manager across the entire NYU Langone Health System. And this program is really championed by Dr. Kim Glassman, who is the Chief Nursing Officer, Dr. Fritz Francois, who is the Chief Medical Officer, and Tom Sedgwick, who's the Senior Director of Social Work. This is really important that this effort is championed by them because I think we would not have been able to do the things we have done without their leadership and their influence. We also have physician champions. We have a hospitalist based on our main campus in Manhattan and another in Brooklyn. And they are considered as hospitalists, but also advanced care planning champions. And that is really important, especially with helping this effort among the physicians and other providers. We have been working to implement and to train our staff in the Respecting Choices Advanced Care Planning programs. And this is the program that our Chief Nursing Officer chose to implement system-wide. We have made a lot of enhancements to EPIC, which I'll be going into, again, to make it easier to document and to retrieve these important conversations and documents to really ensure that we're able to honor the patient's wishes and to ensure that all of these efforts are person-centered. We introduced eMOLST in 2016, and I'll be talking a little bit about the policy. So our program basically oversees any policies that have anything to do with advanced care planning, DNR, things like that. So why did we create an advanced care planning program? We decided to create this program because what we were realizing is that despite increased awareness over the years, the advanced directives were still very limited in nature. So either they did not exist, or if they existed, often even when a patient was completing a healthcare proxy form, there was really minimal or no conversation with their healthcare agents or providers. And so what we found is in emergency situations or where the patient's condition was deteriorating, we might call the healthcare agent and they would either be surprised that they were actually named as the agent, or if they knew that they were named as the agent, they really had not had any conversations with the patient at all regarding their wishes. And similarly, for patients with serious illness or life expectancy of a year or two, we also were finding that MOLST was seldom completed. In fact, until we started this program in end of 2015, I had maybe till then seen a maximum of 5 paper MOLST that kind of walked through our front door. And I can guarantee that all of those 5 MOLST were either incorrectly filled, had contradictory orders, were not witnessed, or were not signed by a provider, or were completed maybe like 5 years ago or more. And so as a result, it became problematic when healthcare decisions needed to be made in crisis. They were being made by people who didn't really know the patient's wishes. There was also limited inpatient-outpatient communication about advanced care planning, so it felt like the right hand didn't know what the left hand was doing. Of course, we are obliged and want to honor the Self-Determination Act and abide by it, and so we felt like we needed to do more than just give materials on admission. We wanted to really enhance this effort. And in terms of the New York City context, which I think is really important to mention, so it's very ironic that despite MOLST, the New York State MOLST and eMOLST having been available for a number of years now, we are actually the only hospital that is really using eMOLST as a standard of care for patients who are DNR or who want any life, limitations in their life-sustaining treatments. So I want to mention this. And also, according to the Dartmouth Atlas, New York State remains one of the states that is kind of number 1 or maybe now number 2 in the number of patients who actually die in our hospitals. So even though research shows that patients would like to die in the comfort of their homes with their loved ones, maybe focusing on comfort-focused care, they are actually receiving quite the opposite care. And my hunch is it is the case because there is not enough awareness about advanced care planning, not enough understanding about the different documents and forms, including eMOLST. And we at NYU Langone are sort of working against the current to really make sure that we enhance advanced care planning and that we really provide opportunities to really allow our patients to reflect on their wishes and for us to help them complete the necessary documents so that their wishes are ultimately honored. So, often I have this sense that I'm kind of climbing this mountain that becomes taller and taller by the second, because we are really trying to lead this cultural shift in the city, and it's not easy, but it sure is worth it because it will allow us to honor patients' wishes. In terms of the mission and vision of the Advanced Care Planning Program, so it is really to promote enterprise-wide advanced care planning in which patients' healthcare preferences are discussed, documented, and honored by families, friends, and the healthcare community. And I make an emphasis on discussed, documented, and honored because these, to me, are 3 important pillars of an advanced care planning program. We could have a quality conversation with a patient, but if it's not documented in an accurate way using the New York State legal documents, if it's not documented in an easy way in the electronic medical records for other providers to be able to find, it makes it less likely to be honored generally. And the vision is that advanced care planning become the standard of care for all of our patients system-wide. I always think about right now, or maybe until right now, advanced care planning has been very much an afterthought. And so we are really working hard to make it move to the forefront of all of the care that we provide, whether it's inpatient, ambulatory, wherever we are treating any of our patients, it should be at the forefront. I sometimes in trainings to providers and to our staff will say, you know, we all pay attention a lot to the allergies that pop up as soon as you open the patient's chart. So too, advanced care planning is as important, if not more important, because we should not be doing things to patients that we know that they don't want. So I'm going to go into eMOLST implementation now. So just to give an idea of a timeline, so we started conversations with Dr. Pat Bomba, who leads the New York State MOLST and eMOLST. And we had invited her to come present to our staff on eMOLST specifically and just MOLST in general, because I have to say, like I mentioned earlier, when we were introducing eMOLST, we're actually introducing kind of the whole package MOLST also, just because there was little awareness. I mean, I remember early on when, you know, Dr. Bomba came, and then we invited Katie Oram, who works with Dr. Bomba, to come train our staff, and then I continued doing these trainings. We would ask people, you know, in the room, how many people in the room know what a MOLST is? And it used to be silence. No one would put up their hands. So, you know, we really worked hard with Dr. Bomba and her team to raise this awareness. And that around the same time, we also were working with Respecting Choices with Dr. Bas Hammis and his team. We had invited him to come and do a grand round and also to meet with our staff. And I think it was our work with both these important entities that really kind of helped us arrive to where we are now. It was a combination of making connections and trying to work with both these persons and their teams to build an infrastructure for advanced care planning, to figure out the best training to provide to our staff so that they can really have quality conversations with the product for these patients with serious illness, frailty, or expected to die within the next year or two or so, with the product being completion of an eMOLST if the patient wants that. So we had an early a meeting early on around the fall of 2015 that included New York State MOLST, our Chief Nursing Officer, our Chief Medical Officer, Epic Leadership, our Legal Counsel, and Social Work Director. And in that meeting, I remember clearly kind of talking about a strategy to implement eMOLST as part of our electronic medical record and to make it, again, easy to connect directly from Epic, which is what we use here at NYULH Health, to eMOLST. It was very strategic to have those particular people in the room and to have really, you know, senior leadership present, as well as legal counsel, because I think it was important for us to be in the same room to kind of talk about, you know, what are our challenges, what are our hopes, and so on and so forth. Steve Chen here, who is a nurse but was a part of the Epic team, is worth mentioning, because after this big meeting that we had that I just mentioned, you know, we were kind of continuing to have conversations, but Steve, without me knowing, was testing this out, was in touch with New York State MOLST, with Katie Oram and Dr. Bomba, and, you know, kind of behind the scenes was really kind of obviously very eager to get this going because he understood the value of it, having been a nurse himself. And lo and behold, one day he was like, I think we're ready to launch eMOLST in about a month or so. Are we ready? And I'm like, yes, we are. So it was just amazing the work that he did. So we did launch eMOLST in August of 2016, and we do have a single sign-on setup between our Epic and eMOLST, so there's no needed. So basically, once you sign into Epic, you have access to eMOLST, and there's no other password or username needed. It's a very kind of easy way to sign on. We initially started with a staggered implementation. So initially, in August of 2016, we provided training and access to the palliative care team and to the geriatric care team. But very soon we realized that in order to ensure that the patient's wishes are honored, we need to kind of quickly put in place a strategy that allows all of our staff to have access. They do have different access, but it's important that wherever the patient kind of encounters our system, that our staff are trained to know to look for the eMOLST and are able to pull up that form very quickly. And so I would say by around November of 2016, we pretty much had all of our main campus with access to eMOLST. We did a lot of training. First, again, with Katie Oram coming, I think she had done about 2 or 3 days of training, an hour and a half training for our different staff. And then I was able to take that on. And over time, we also developed an e-learning, which is about 15 minutes long, and tip sheets in order to support our staff. Having said that, I also do continue to spend time, coaching our staff one-on-one, because I feel that sometimes that's really another really good way to help people feel comfortable, having these conversations and also completing the documents. The staff training also focused on the Respecting Choices programs, which I'll be getting into a little bit more. But for us, it is very important that it's not just about the form. In fact, the form for us is very clearly a product of a quality conversation. And we do use Respecting Choices to have these important conversations. Maybe just a word in terms of the access to eMOLST. So in New York State, so the physicians, and for NYULH and Goan, it's attending physicians, and more recently, nurse practitioners have been, a law has been passed allowing nurse practitioners to be able to sign DNR orders and eMOLST, and also to be able to document patients' lack of decision-making. So that has been a really welcome change for us. So nurse practitioners and attending physicians here at NYULH and Goan have access to the highest level of eMOLST, which means they can complete it, they can review it, and they can sign it. After that comes the ability to draft an eMOLST, but not be able to sign it. So, for example, I as a social worker can have a conversation with a patient, and then I loop in the physician or MP before and of course after, and then we're able to complete the process, because then they are able to sign it after having witnessed that these are the patient's wishes and being available to answer any questions that the patient may have. So the social workers and PAs have that kind of access. The nurses and the unit clerks can access the eMOLST just by being able to know if there is an eMOLST or not, and they can download a PDF of the eMOLST. So again, they're able to then raise that awareness among their team that this patient has an eMOLST. So this is the New York State MOLST, just the front page of the paper version. We have in our training raised a lot of awareness about the difference between the MOLST and advanced directives. So we always emphasize that the MOLST is signed by a physician or nurse practitioner, and so it's an actionable medical order. It travels with the patient wherever they go, and it's under the node care settings. And that's why this becomes, therefore, the gold standard for documenting these important decisions, because it really allows for more detailed conversations, more coordinated care, and importantly, person-centered care. We also raised a lot of awareness and provided a lot of education about the difference between the resuscitation instructions, what the patient would want if their heart or breathing were to suddenly stop, versus what they would want if they had any complications from their medical condition. And those wishes for those sort of complications come into Section E of the eMOLST. This in itself, so the MOLST coupled with the Respecting Choices Advanced Steps training is really what helped us bring about this cultural shift in terms of the language we now use, in terms of this important distinction between, again, the resuscitation instructions and other life-sustaining treatment, and the importance of documenting these decisions in the moment of the conversation. So we've done a lot of training around that. So, you know, we had a lot of pushback in the beginning that people were thinking that the MOLST should only be completed on discharge from the hospital when the patient is leaving. And I kept pushing and saying, you know, no, this is a document that once you've had a quality conversation, you need to be using this document so that we're able to document the patient's wishes, you know, according to that conversation. We don't want to be going back to the patient or to their family members because now the patient has lost decision-making capacity to have this conversation again when we've already had this conversation a number of days ago with the patient. Again, trying to really emphasize person-centered care. We should not be burdening patients with multiple conversations unless they are the ones who need those multiple conversations, in which case, of course, we would absolutely make that happen. So kind of this has also helped us. I keep thinking to myself that, you know, person-centered care means we have to move away from system-focused care and really kind of make that shift happen. This is an example of what we would see for patients who have an eMOLST available. And the nice thing about it is, you know, again, it separates, it provides a summary of orders when you click on the eMOLST button. And it separates them by resuscitation and life-sustaining treatments. And then it also allows you to open the PDF, which will give you, obviously, the complete form. I mentioned this already, the distinction. And in our training, we also, you know, really focused on the importance of understanding what CPR means and being able to educate our patients on what CPR means. Because in the past, we used to be okay with patients saying, yes, I would be okay with the chest compressions, but yeah, I don't want to be intubated. And so we've done a lot of education around, you know, around the fact that CPR is a package. There are many different components to what CPR is, and it does include intubation. So for those patients who are saying they don't want to be intubated, then we need to provide more education so that they can make a decision that really aligns with their goals, values, and beliefs. Okay, and this is Section E of the eMOLST. In New York State, in addition to completing the MOLST, if one is completing a paper MOLST, there are also several checklists that need to be completed according to the patient's situation. And the checklist allows one to ensure that the legal requirements are being met. The nice thing about eMOLST is that the checklists are incorporated in the eMOLST, and so one doesn't have to worry about that. From my experience, anytime that we have seen a paper MOLST in our system, it has never included the checklist, which really means that it's not a complete form. So the eMOLST also allows all of these checklist to be incorporated according to the patient's situation, and very importantly, it makes it then a more complete and accurate form. And the other advantage of the eMOLST is that it doesn't allow for contradictory orders, so that if one shows that the patient wants CPR in section A, you cannot choose comfort focus care in section E. It just won't allow you to do that. It will white out the options that are contradictory. We provide education about eMOLST Review Renew and who it's appropriate for. And this is, gives you an idea of how we are doing with eMOLST implementation. So early on in 2016, it was literally pulling teeth. Also with teams where we thought we would get a lot of buy-in, it was not easy to implement. But, we've been slowly doing better, and so it's encouraging. We also changed our hospital policy to stipulate that any patient who is DNR or wants, any limitations in life-sustaining treatment, of course, any patient who is appropriate for eMOLST, that is the preferred form to complete. We never force these forms on patients. So if, they tell us that they don't want to have an electronic MOLST, we will give an option of the paper MOLST, or if they don't want that, then we would complete our own internal form. But I think changing the policy and raising the awareness has been an important component of getting more providers, more teams to really use the eMOLST, when appropriate. This here is our patients with DNR Code Status, just an idea of the advanced directives completed, which, as you can see, they haven't really gone up, but it is higher when compared to the average for patients who are not DNR. It's really, for us, hovers in the 35%, and nationally, I think that's sort of around where it is also, around 33% for patients in general. But you can see here in terms of the advanced care planning note completion, we started in around 20% in July of 2017, and we're over 50% right now. Of course, we'd like that to be 100%, but we're, I think doing better. In terms of most completion for patients with DNR, you can see here also, we started around 18% in July of 2017, and we're up to around 73% now. So we have, I think we're making really good progress. For me, what is important about all of this is not necessarily the metrics just for the sake of, but, I think the chances of these patients' wishes here being honored is really multiplied by so much when compared to these patients. If they had our internal form, I think that would have been more, there would have been more opportunities for breakdown in communication and for lack of coordination. So I'm very happy with these, with these metrics, because I think it really allows for patients' wishes to be honored. And we actually did conduct a quality improvement project here where the coordinator on the advanced care planning team, with my guidance, she looked at 54 charts randomly, and they were for patients who are marked disease on eMOLST and who are NYULH owned patients. And what she found is in 98% of the 54 patients, so basically 53 of those 54 patients, we did provide concordant care at end of life when, so we basically provided the care that was stipulated in eMOLST. And the one remaining patient, we don't know that we didn't provide concordant care. It's just that we could not get information because the patient was home but had not yet started hospice, so we don't know exactly if that patient's wishes were honored or not. But that's pretty significant to be at 98%. It's I think it tells us clearly that and eMOLST can really allow us to honor patients' wishes much more than any other form that we previously had. So I'm going to talk a little bit now about our electronic medical record and what we have done to enhance advanced care planning. So we are very excited that in January of 2018, we were able to implement the Advanced Care Planning Navigator in Epic. We did a lot of work in working with our Epic team here that are just really amazing and so committed to this effort, being in touch with the Epic Foundation and, looking at other organizations to see what they had in their systems so that we could also not necessarily reinvent the wheel, but kind of really try to take from the best practices of the different organizations. So in our Epic now, we have an Advanced Care Planning tab here to the left, and it gives us the ability to do a number of things, which I'll be going into shortly, but basically, we can document the healthcare agents, we can document the patient's capacity, and activate the healthcare agent. It allows us to review the code status, to look at the response to the mandatory surprise question, which is, would you be surprised if your patient died within the next 6 months? Evidence-based wise, it's usually 1 year, but we have it here as 6 months because it kind of goes hand in hand with the Palliative Care Information Act. We have the possibility here to link to eMOLST. We can review advanced care planning documents that include all scanned advanced care planning related documents like the healthcare proxy form, living will, eMOLST PDF, etc. It allows us to create an advanced care planning note or to review an advanced care planning note. So we'll get into the notes in a second, but the nice thing is just from the screen, you can actually see if a patient has an advanced care planning note, and you can very quickly review it as opposed to needing to go to the progress notes and kind of go to all the different notes, which we know people often don't have time to do. You will also see that our code status here is listed above. That's just the resuscitation order, whether it's DNR or CPR. If the patient has a MOLST, we, in addition to having access to the eMOLST, which is the electronic version, we also print and scan the eMOLST so that it is also in our record just in case, eMOLST is down. But by virtue of scanning the document, this lights up MOLST yes in pink because that's the color of our form. And that was something that our ED providers in particular were really pushing for an easy way for them to know that this patient has a MOLST, because they felt like in an emergency situation it would be good to have it in the patient banner, so we were able to do that. And this here, HCA active, lights up when the patient lacks capacity, and the providers have documented that. So, sorry, this is not showing very well, but just to show again here, so once you click on the MOLST button in the Advanced Care Planning Navigator, there is then this open eMOLST, and by clicking on that, it takes you directly to the New York State MOLST registry to see the actual form there. It makes it much easier also to review and renew directly through eMOLST because you don't have to keep creating new documents. You just kind of can build on those earlier conversations and the earlier document, again, making it a lot more person-centered and definitely less tedious for the providers because everybody is building on the previous efforts. And that's something that we have really pushed in all of this effort to emphasize, that we don't want to be having 5 conversations in the same day with the patients from different teams and providers. We want to really make this person-centered, and so I think this really allows us to do that. This is just some information about how the nurses document advanced directives. Again, they're encouraged to look first to see if there is an existing healthcare proxy form in Epic, and if it is present, to confirm with the patient if it's accurate, valid, and if not, they can either facilitate an advanced care planning conversation themselves, or they can refer to social work or to our team to be able to assist with that. This gives us the ability to document who the healthcare agent is, first alternate, second alternate, put in their phone numbers. And this is the section that addresses documenting decision-making capacity. So the attending or NP1 first would click on this button, and they have a template that basically meets the New York State legal requirements. They just need to fill in the blanks where they're saying, you know, the cause and the extent of the incapacity and the likelihood that the patient will regain decision-making capacity. And the second person who clicks on attending NP2 basically says, I concur with that first provider. And then when they click on incapacitated, this healthcare agent active appears. The advanced care planning note is another important component of these conversations, and that goes hand in hand with eMOLST. We do ask our providers to always use this note type whenever they are having a conversation with our seriously ill or frail patients and with whom they're completing the eMOLST. We have embedded some of the respecting choices language, especially in the conversation section here. This year, ACP Conversation General is more intended for conversations with healthier adults and adults with chronic illness, whereas this section here goes more into, you know, what is the patient's understanding of their medical condition, what is their understanding of complications that may arise, goes into their understanding of CPR, their goals for CPR, unacceptable outcomes, and so on. And then here it goes into, you know, was a new eMOLST created or was an eMOLST revised, healthcare proxy, and so on and so forth. This note type for the provider, so for NPs and physicians, can also serve as they can easily drop the advanced care planning billing code charges, the 99497 and 99498. And you know, we've also been making, trying to raise awareness about these billing codes, and our EPIC team helped us find a way, an easier way for these providers to drop charges directly so that they don't have to go to another area to be able to do that. These are our actionable advanced care planning notes. I say actionable because the data that you see here, so we have now probably more or closer to 11,000 notes in our system. Advanced care planning notes, both on the inpatient side and also ambulatory settings. I say actionable because this data here is only pulling those notes that have significant information in them. So if somebody just started the note but then didn't put anything in or just kind of completed the bare minimum, it's not reflected in this chart here. It just would never even be included in the report. This here shows the number of patients who are DNR who have an advanced care planning note completed on discharge. Right now, this data here particularly is only for inpatient, but we're in the process of building an outpatient advanced care planning dashboard that will allow us to have data more easily available for the ambulatory site. What this chart shows here is the purple is for NYU Langone, Tisch and Kimmel, which is our main campus, and the yellow is NYU Langone, Brooklyn. And these are the billing codes, which I'm sure you're aware of. And this again, for the billing codes, you can see that, you know, we started really low here, but we're slowly making progress in terms of the use of these codes. You know, I emphasize when I do trainings that it's not just about getting the reimbursements. It's also about, you know, showing CMS that we are having these conversations so that hopefully over time, you know, maybe more reimbursements and other strategies to kind of enhance these conversations are also figured out. The change of code status orders was another big one that again went hand in hand with our work with respecting choices and New York State's MOLST. So when we introduced MOLST, we figured out that we can't really continue operating on our previous code status orders because there's going to be, it's just not going to make sense. And the previous code status orders were full code, limited code, which was quite an enigma and meant something different for different people, DNR and DNR comfort care. So it took a lot of effort, a lot of training, a lot of kind of discussions with key stakeholders to transition to what we have now. Especially, we struggled a little bit with this DNR comfort care. I think people felt ironically comforted by having DNR comfort care in the banner for those patients who are not only DNR, but who also were patients who are either on inpatient hospice, who are not wanting any life-sustaining treatments, but who wanted to focus on comfort-focused care. With a lot of education and communication over time, that kind of did not remain an issue. I think people now really know to look at the chart, and it has not really been an issue anymore. This limited code comes up every now and again, but hardly ever. So again, I think we've really made the transition beautifully. So what we have now is what appears in the banner is either CPR or DNR, because that's something that staff need to see very quickly if the patient's heart or breathing were to suddenly stop. What we did do, and this was all introduced also in January of 2018, at the same time that we introduced the Advanced Care Planning Navigator, what we did is we basically mimicked MOLST into our electronic medical record in EPIC so that the two are exactly the same. We also made it a point to include the definition of CPR because we wanted to make sure that our providers really understood exactly what CPR meant, and to be able to really use this language when communicating with patients and families. There is also here a field that says, I have reviewed the up-to-date MOLST, and it matches the code status order, or there is no MOLST. And then the next one is an example of a patient who has a DNR order in Section A, but otherwise does not want any limitations on medical interventions. So once you click on this no limitation on medical interventions, it only gives you the options that it does give you in eMOLST. So the two are identical. And again, this means that the code status order options that you cannot enter any contradictory orders. The other big change that we made is that the code status orders can also be entered in the ambulatory setting, and if they are entered in the ambulatory setting, they remain active across encounters. But if the patient is admitted, the providers, of course, need to confirm that these remain the patient's wishes, and they need to kind of confirm that order or enter a different order. In terms of staff training, again, I think I alluded, we did a lot of training on eMOLST, a lot of training on having these important conversations using the Respecting Choices program. The Advanced Steps program, of course, goes really hand in hand with this, as well as the Shared Decision Making in Seriousness program, which is a newer program for Respecting Choices, and which is one that we're also trying to implement more here. But the importance of using accurate language, I think, has been really key. In all of the trainings we do, of course, we always mention the POLST program because we want people to know that we're not alone in this, that there are all the other states in the country, or many other states in the country that have a similar program. And so I think that's really important to help people feel that our effort is one that is the effort of the country. Okay. So this is just some feedback from our patients and families when we're having these important conversations. I think the one thing that we hear all the time from our patients, one is, thank you so much, for providing this opportunity. We keep hearing that, I really never had anyone explain to me what CPR is. I never knew that intubation was included in CPR. And so they really appreciate the information and in an accurate and in a, in an easy flowing conversation. And I think they're appreciating that it's not an easy conversation to have, but that with providing this important information, accurate information, they're really able to make an informed decision. We, of course, in these conversations are always including the healthcare agents. That's a real important part of all of this, because they will need to be they will be eventually at some point or another in a position to need to make additional decisions on behalf of the patient. So they need to be part of these earlier conversations. In terms of collaboration with community partners, we know that to provide person-centered care, we cannot do this on our own. We have to engage all of the other providers that provide care to our patients. So, of course, working hand in hand with New York State MOLST has been absolutely key. We work with the Jewish Community Center. They have been implementing the First Steps Respecting Choices program, so we work hand in hand with them. We have been working with our main EMS provider, which is Senior Care, and we actually just had a phone meeting just a few days ago, which we're really super excited about. So, it's been my wish that EMS not only understand what MOLST is and honor our patients' wishes and make sure they have a copy when they're transporting our patients, but we would like them to, go live on eMOLST, and they seem to be really excited to do that. And they're trying to see how not only to be able to implement eMOLST for Senior Care, which is our main ambulance provider for NYULH Health, but to be able to do this citywide and to push that effort, which would be just amazing. We have been also working with VNS Hospice, where we convinced them to also adopt eMOLST, which they did a few months ago. And more recently, we also worked with them to provide the Respecting Choices Advanced Steps training, because they were feeling that their staff did not have enough skills to be able to have these important conversations. We're also working with subacute, with the nursing homes, and with specifically with the preferred provider network. So we have a set of preferred subacute facilities, and we're encouraging them to also implement eMOLST, and also as importantly, to really communicate and find strategies for us to together work toward enhancing advanced care planning. We recently had a presentation and a meeting with several of these partners, and we kind of were discussing, how can we make sure that our patients' wishes are honored? How can we make sure that we really provide quality advanced care planning? And so we were really able to identify some key gaps and develop a strategy. We have this in our EPIC for patients' wishes when they're not honored. We encourage any of our staff to enter basically this incident report that then is followed up on. And in terms of patient education, public outreach, in addition to the Joint Commission and CMS required documents, we also provide this Preparing for Life's What Ifs flyer that includes information about MOLST. Again, uses very kind of, non-threatening, very gentle language. We have actually received a number of calls from patients who have found this flyer either in their doctor's office at the cancer center or who were admitted and who saw this flyer and called us. We also, in the welcome books on the inpatient units, there's also a section about MOLST and what that is. We participate in the National Healthcare Decisions Day, and we raise awareness about MOLST also for those appropriate patients. We conduct group sessions. And then on our main NYULH website, we have a section on advanced care planning that also includes information about MOLST. And that's it. We have 10 minutes for questions if you have any.
Thank you, Christine. Excuse me. So if people have questions, feel free to type them in the chat box. And while you're thinking, I will start off with two questions that I had. The first if you wanted to go back to the slides, we can do that, was from slide 19. You were talking about completion rates. And I just wanted to clarify that you were talking about Langone trying to get 100% completion for advanced directives, but that for POLST, you're not looking at 100% completion. That's not a goal, right?
Oh, no. Yeah, thank you for clarifying that. So this here is MOLST completion for patients who are DNR. So what we still find in this area is that there are still times when providers, and this is only for inpatient, just to clarify this slide, we still have providers who are having conversations with patients, and the patient says, no, I would not want to be resuscitated, and they don't complete any form substantiating that order. So what we're working towards here is a compliance of as close to 100% as possible. We know that there may be some patients who don't want an eMOLST, and in which case we would never force a patient to have one. We would offer a paper MOLST, and if they don't want that either, we would then complete our own internal form. But this is what I was referring to when I was saying, so we strive here to be closer to 100, but we have made significant progress from where we were, earlier on.
Oh, definitely. There's a question from Alice. She says, thank you for this presentation. If a patient who has completed an eMOLST comes back to the hospital unable to communicate and no surrogate present, do you rely on the previously completed eMOLST, or is there a process for validation that the form is still consistent with the patient's wishes?
That's an excellent question. So, typically we obviously would try to reach out as quickly as possible to the healthcare agent or surrogate decision maker. And that's why, with our current advanced care planning navigator, it makes it much easier to find those people and their numbers. But we would otherwise honor the eMOLST that is, in the system, because we want to make sure that we're honoring our patients' wishes.
And I think my second question is somewhat related to that, and I was thinking about it for our slide 21. You were talking that you scan the eMOLST or the MOLST form into Epic in case eMOLST is down. And I'm wondering, can that then cause confusion if people look in Epic and are looking at that PDF instead of going to the eMOLST link? I was just trying to think about if a person updates their MOLST in another place, how confident are you that with the system, the way you have it set up, that you're always looking at the most recent document?
So that's an excellent question. And I think, with this comes the challenge that if we are the only hospital that kind of uses eMOLST really consistently, then, yes, what happens if the patient goes somewhere else? So we are working with Epic Foundation, our Epic team here, and, Dr. Bamba's team from New York State MOLST, because our ultimate goal is to have bidirectional interface between Epic and eMOLST. It is our understanding that today that kind of doesn't really exist, but we are, looking into this some more and looking into how HIE, might be a way to help with this. In terms of downloading the eMOLST PDF and scanning it into Epic, it was really our legal counsel who felt like, that we really need to have a copy in there just in case. But we do educate our staff to not rely on that document, but to really go to the source of truth, which is the registry.
And the follow-up question. Oh.
We also do a lot of education with our patients and their healthcare agents to say that, we're giving you a copy, and if you think anything should be changed from here, please reach out to us or speak to your provider so that this can be changed. You can change it at any time.
Okay. And that might have answered my next question, which is one of the reasons that it's helpful to have a registry and that bidirectional capability is that if the patient voids their form, already we know it's a challenge for the patient to let healthcare professionals know that it's been voided, but is there a process right now that if they void it and it no longer exists in eMOLST that you're aware enough to delete it from your Epic system?
Yes. So basically what we do is, we do have patients who sometimes will change their mind. We also have patients who, it's more with the paper MOLST. They come to us from nursing homes and they're not even appropriate for a MOLST, but they come with a MOLST and they often discover when they're here that they have a MOLST. So yeah, we usually would void it. I mean, that's sort of an ongoing issue. So if it is in an eMOLST, we will void it, and it's usually only the provider that can void it electronically. The patient themselves cannot void it, and neither can I, for example. It has to be DMP or the attending. We then print out that voided version, and we'll also upload it in Epic, just so that it's clear that this document has been voided.
Great, thank you.
I think in the meantime, I'll just say, it's been a journey, and I think it's not a perfect system by any means right now, but I think, the change we have been able to make in terms of, again, using, POLST, New York State MOLST, I think it's really been sort of very impressive, and just the feedback from our patients and families is really, I think, the driving force, behind all of this. So, yeah, just want to say that.
Yeah. All right, well, I'm not seeing anything else, so thank you, Christine, so much for sharing what your experience has been and how your system works. I think it's always helpful to see what people are doing, to be able to talk about that, learn, and try to get to the ideal. And I know that you've been involved with our Technology Consensus Project as well. People can find more information on POLST.org about that. So thank you for doing this and for sharing with us. We really appreciate it.